Welcome to Stago Educational Shorts. Short lectures covering the essentials of key coagulation topics. Presented by world-renowned experts. And designed to fit around your busy schedule.
Thanks for joining us for this Stago Educational Short. Today we're joined by Stephen Macdonald. Stephen is the clinical scientist at Addenbrooke's University Hospital in Cambridge, where he's been in post for over 20 years. He has a special interest in bleeding disorders and also the control of quality within the pathology laboratory. And he has a special interest in the uncertainty of measurement and statistical control techniques.
Hello and welcome to today's Stago Short. My name's Stephen Macdonald. I'm a Principal Clinical Scientist at Addenbrooke's Hospital in Cambridge and have been for 20 years now. I, over my period of my career in the haemostasis lab, have developed quite a strong interest in medical laboratory statistics, some topics of which are on the slide here, and it's on those topics that I'm going to talk about today, particularly about comparing samples and what methods are available to us in the laboratory to maintain quality management processes. So I will be talking today about some Stago products, but as a disclaimer, just to state that Stago played no role in the collection of this and the setting up of the presentation, so these opinions are all my own. The problem with comparisons in medical laboratories is everything that we do is basically based around comparisons. We check patient results against reference ranges. We compare analyzers to make sure they're giving comparable results. We make sure reagents are the same when we change lot numbers of reagents. So we're constantly looking at comparisons. And particularly now with ISO 15189 and UCAS accreditation, we are required to do a lot of work now to demonstrate that what we are doing is comparable across our laboratory networks, particularly now that we have pathology laboratory networks and many hospitals which are producing results with the same technology, the same analyzers, the same results, and we need to be able to demonstrate that things do compare. So today we're going to take a quick whistle-stop tour of some of the approaches that we can take. And particularly a lot of the questions that are required of how can we be compliant with the quality management processes that we need. So I suppose the first question to really ask is, why would results not be comparable? Surely if we're using machines and reagents that are standardized, provided by our suppliers, they should be directly comparable. Why wouldn't they be? So in hemostasis we use a lot of calibrated assays, and we're very much reliant on those calibrated assays being calibrated correctly and consistently across the different analyzers and reagent platforms that we use. Those calibrators themselves have to be traceable, metrologically traceable to higher international standards, and therefore have to demonstrate that they are commutable to patient results and also to those international standards. And failure to achieve that can really cause quite a lot of problems with results not being comparable across platforms. Even if we do comply to that and they are calibrated correctly, we can have problems with drift over time as well. Calibrations have a finite lifetime. We have to have a regular calibration schedule to make sure that the calibrations are stable over time. And of course we do measure different measurements across different measurement methods as well. So one technique might give a result for the same measurand that is compared to another technique which might be slightly different. Reagent lots are less of an issue now than they used to be. We used to have constant reagent lot changes and suppliers are very supportive for our requirements for that. However, they do change over time and we need to make sure that patient results are consistent across reagent lots, and that there's other things that can impact comparability as well as reagent age on the machines, different dilutions, etc. So the first question that people always ask with regarding to testing for comparability is, what samples do we use? What samples do we have available to us? What options do we have to be able to demonstrate our quality processes. In particular, first of all, what concentrations do we need to consider? Measurand concentrations should be measured across the entire range, the measurable range of the assay, and as much as possible we should try and focus on critical decision points, clinical decision points, because obviously that's where the comparability really affects us most. But really we should be trying to do a wide range of results across the entire measurement range. Sample type, where do we get the samples from, how do we store them, how do we process them? Some assays will lend themselves to having only to be tested by fresh samples, and that can cause a problem if the samples aren't readily available. If we don't have to rely on fresh samples, sometimes we can collect them prospectively and batch them together. Again, we're making the assumption that the samples are available and that our storage conditions don't affect the results, and we'll come to that in a little while. The big question that people always ask is how many samples? How many samples should I be aiming for to demonstrate comparability? And I think it surprises a lot of people when we talk about comparability that actually you don't need as many samples as you may think, but it is entirely dependent on what the comparison you're doing is. If you're doing a full validation and verification, then of course guidelines state that you need a lot of samples, and that's only right. But if you're doing reagent acceptance testing and lot comparisons, the sample number is a lot lower than you would think. And what that's guided by is by the statistical power of being able to detect an error if it's there, and obviously reducing the risk of detecting an error that doesn't exist or not detecting an error that does exist. And there are guidelines, particularly from the CLSI, which indicate what the best number of samples are to approach that. And it's all down to what the critical difference you expect to be acceptable for your assay is. But a very, very important thing with samples is commutability. We cannot just use quality control material. And this is something that perhaps a lot of people think is sufficient and all we need to do for comparisons, but actually we need to think about patient samples as well. And that is because we need to take into consideration the sample matrix. So what's the sample matrix? The sample matrix is basically anything within a sample that isn't the measurand of interest. So the measurand, obviously defined during our measurement uncertainty assessment, is the specific part of the sample that we're trying to quantify, and anything else that is within that sample that may interact with that measurand and cause a change in the result is something that may be effective in the matrix. And that's something that we need to consider for quality control material, EQA material, but also for our patient comparisons. So in selecting our patient samples, we need to make sure that the source of those patient samples is consistent with what we're going to be testing for clinically, and that there isn't anything that's going to be erroneously high or low that we're not measuring that will impact the result of the measurand that we're measuring. Other simple things, biochemical things like ionic strength, changes in the enzyme activities and interactions with substrate can also alter the behaviour of the matrix. So collection of these samples must be done in a very controlled manner. And the stability of the samples as well. How long are they stable for? If we're using fresh samples, are they stable for a period of time? Are they hitting the same analyzer or the different analyzers at the same time, or at least in a way that's not going to impact on the results and introduce error that isn't associated with what we're trying to compare? How much volume do we have? Again, if we're relying on fresh samples and we don't have a high availability of samples, we might not have an awful lot of volume to play with. So we need to consider maybe we do need to go to a batched process, and if so, do we need to think about what the minimum volume is that we require for that. There's other practicalities as well. There's staff time that this takes. Do we have to disrupt routine testing? Is it going to interrupt our routine laboratory process as well? So when we're talking about comparisons and comparability, there's a lot of factors we need to consider. So what options do we have? Option one, we can collect our own samples. We work in medical laboratories. We have a lot of patient samples that go through. We are allowed to use patient samples for quality assurance processes. That is part of the Human Tissue Act. But in hemostasis, we have to be very careful about how we handle those samples. We need to remove them from the cells as quickly as possible. make sure they're capped and not exposed to the air as much as possible, because we do get buffering problems with some measurans. And when we do cap them, make sure that there's minimum headspace, because we can get sublimation of the samples, evaporation effectively, and buffering of the samples with the headspace. And there's been some very convincing work done in the field of thrombin generation recently that shows that minimizing the headspace can have a very significant effect on the results that you obtain. Usually in hemostasis we will need to batch the samples to measure our specialist measurans. We will need to then store them, and guidelines state that they should be stored at less than 70 degrees Cs. Usually freezers are around about -80, so they are stable at that for a period of time. You can, if you need to, store them at -20, but that should be only for very short period of times. And I know ourselves in Cambridge, we always store everything at -80 to make sure that they're suitably stored for a period of time. We know that repeatedly freezing and thawing plasma samples will impact on certain measurans activity. So we need to make sure that if we are storing them down and we're planning using them for multiple runs, aliquot them out into a number of aliquots, again taking care with the headspace and making sure that they're capped. But make sure if you're going to defrost a sample, you defrost it, you run it once, and then that's all it's used for. It's not used after that. If samples are in short supply, we could pool samples, but again, a note of caution, this should only be done if the availability of the samples is very low, and we have to be careful that pooling of the samples doesn't affect the sample matrix. And really, that's something that we have to be very, very careful about. We now know that we have to run these comparability tests prospectively. We do have time on our side for collecting samples, although samples at clinical decision points can be sometimes difficult to get our hands on. Pooling samples, in my opinion, should really be a last resort, because we're introducing potential sources of changes in the sample matrix that we're not controlling for. And that's the bottom line. Remember, we only want to detect differences that are attributable to the methods that we're actually trying to compare. But there's always going to be differences. Things are never absolutely going to agree 100%. So what's good and what's bad? And we'll come to that in a minute. The second option that we do have is we can get somebody else to do it. We can get somebody else to collect the samples for us. We can get somebody else to collect all the samples, store them in a consistent way, handle them in a consistent way, and then send them to us so that we can then use them. And this is where Stago have a product called Expert Core, which is a series of plasmas that can be used for some of the routine measurans within hemostasis, and can be really, really useful in reagent acceptance testing, network laboratory testing across laboratories for the routine measurans that are used. And more published data is coming out with regards to how Expert Core performs on this. We have a poster here that was presented at ISTH in 2020 that shows that actually it's capable, or the plasmas are capable of showing a high degree of comparability across 2 Stago platforms, demonstrated in the table here. But I asked earlier, what's the impact of not being comparable? How do we determine what's comparable? And we really need to think conceptually about what we're actually using our laboratory tests for. At a high level, we're using it for one of 2 things: either first-time diagnosis of a patient, in which case the comparability that we're trying to achieve is comparing the patient result to reference intervals, or reference ranges as we call them in the lab. So it's a single result being compared to a statistically derived normal reference population. And the impact of these not being comparable, and the impact of that would be that a misdiagnosis, so they would either be diagnosed as having something or not diagnosed as having something when they do have it. It could be very, very severe. It could be a delay of treatment. It could be unnecessary treatment. It can have financial implications, psychological implications for patients. And that's extremely important, that we need to consider that our results must be comparable to those reference interval as they were determined originally. The second use case is for longitudinal measurements of patients over time. And we see this particularly in hemostasis when we're measuring patients who have already had a diagnosis of a disease and are then we're checking to see how they're responding to treatment or whether they're at risk of relapse. And in that case, the comparability is the comparability of results within a given patient. And that has a really high demand of comparability. The bottom line is the patient getting worse or are they getting better? And this triangle hierarchy on the right-hand side of the slide really indicates what sort of standards we should be setting for ourselves for determining whether things agree or not. And this is from publications from the chemistry field back in a meeting in Milan in 2015, extending from the hierarchy of the Stockholm meeting in 1999, where the gold standard of how we should be testing if results are comparable or not should be through clinical outcome studies. In hemostasis, we're largely reliant on the second rung, which is biological variation, which is comparing the effect within a patient and between patients. So within a patient is intra-variation and between the patients is inter-variation. And that's what we use. We know from data that's been published and is freely available what we expect our measurements to vary like within and between patients, and that's the standard that we have our assays held to. So how do we use that? How do we incorporate that in comparability? We need to know what the imprecision of our assays are, because the imprecision will have an immediate knock-on effect of what our interpretation of the results are. So we need to run both of the assays in a consistent way in both methods, keeping everything controlled that we think could impact on the results. And once we know what the imprecision is, we can run the results and compare the results between the two different methods. And importantly, we're calculating the differences. And including in that is the average difference between the methods as well. And that average difference needs to be compared to the critical difference. And that critical difference comes from our biological variation or clinical outcome data. So there's two aspects that we need to work out statistically, whether things are actually comparable or not. The first being the analytical difference, which is related to the imprecision of both of the methods combined. And provided, as we would hope, the imprecision is the same across both methods, we can multiply the average CV between the two methods by 1.41, which is an algebraic transformation of an equation, which basically means the square root of 2. And in doing that, if we want to compare it to 95% confidence, as we're always wanting to do, we multiply that by 1.96. So in general, we have the CV of method 1, the CV of method 2, average that, and then multiply it by 2.77. And that will give us a limit for what the critical difference analytically should be between the two methods. But also, if we're using patient samples, we need to incorporate the biological difference as well. And in doing so, we need to incorporate our biological variation into that. And you can see from this equation here that we are incorporating the analytical coefficient of variation and the biological variation as well, multiplied by the same factor of 2.77, which gives us a coverage interval over which the differences should lie. Going back to the expert core plasmas, these methods have been used, and again recently published last month in the International Journal of Laboratory Hematology. Additional statistical methods which are recommended to use for comparability methods include passing Bablock regression, not simple ordinary least squares regression. Passing Bablock regression is robust to outliers. There is an argument that we should be using weighted Deming regression as well, because that accounts for error within the actual results that we're measuring, and I think that is actually good practice to be using that as well. But secondly, also Bland-Altman analysis, which has since 1983 been the de facto standard for measuring comparability between methods. It checks to see whether there is a concentration-dependent difference in the methods. So these are two methods that should be applied to comparability at all times. In this paper, they used literature-based targets for comparability as well as manufacturer recommendations, and manufacturer recommendations may come from instruction for use, existing data from manufacturers, or even locally derived data as well. And importantly, what they've done in this paper is demonstrated what we should be doing as good practice, showing that our comparability means that our results are transferable to the reference ranges that we apply, because a lack of transferability will immediately inform us that we need to change reference ranges. And we have seen this quite regularly in Cambridge, where we will see a lot number change that will show a change that means we need to change the reference range. So in conclusion, peer review has never been more important, comparing ourselves to our colleagues, to our networks, but even comparing analysers, reagent lot numbers, etc. Comparisons are everywhere. We do them all over the place. We need to use a really well-defined framework, which hopefully we've discussed today. We've always known that this is important, but it's really refreshing now that we need to put the pressure, if you like, on our suppliers to provide us with products, provide us with means by which we can achieve comparability, or certainly achieve a method by testing our comparability. And that's the conclusion of the presentation. Again, I would like to thank Stago for inviting me to talk to this. Thank you. It depends. It's got to be data-based, so you can't really have a one-size-fits-all. A lot of things will lend themselves to regular schedules, but I would recommend, first things first, you have to do it based on data. So if you know things are liable to slip out of comparability, for want of a better phrase, over a period of time, you want to make sure you do your comparisons within that time frame. There's no hard set in stone guidance as to how often calibrations should do necessarily. There's even discussion whether you still run real-time calibrations with some factor assays. Stored calibrations are something that have particularly come into the field more notably in recent times, but what the period of stability of those calibrations are needs to be investigated locally, and that will be determined by your reagent combinations, your analyzer combinations, and your local running environment. If you have a schedule, the first thing that, if I was an assessor and I was assessing you and you have a schedule written down in your process, I would want to know where that schedule came from. I would want to know why you've set it at 3 monthly or 6 monthly. Some things will need to be done more regularly, and that'll be based on whether you've demonstrated non-comparability in the past, whether you've had issues with your EQA, whether you've had issues with your IQC, whether you see drift in your measurement uncertainty. All of these things, as I tried to show in the first slide, are all dovetailed into each other. They're all linking together. So it's not a one-size-fits-all. It's an overall quality management process. So if there's any indications that things are regularly going out of specification, increase your comparability. If you can then show that it's more stable through doing some changes or preventive maintenance or etc., then you can extend it. So there's no depends in this answer. It's an absolute yes, of course you should. I suppose it depends what the comparability is you're measuring. I mean, if you're comparing it against previous results and you've stored them, then that doesn't really work. So when you're doing comparisons, as I said in the presentation, things have got to be consistent, run at the same time, samples run at the same time, handled in the same time, thawed if necessary at the same time. We need to ensure that all pre-analytical variables are accounted for and controlled for, so that we are verifying across the same thing. Because the last thing we want to do is to have to implement a lot of corrective actions and raise non-conformances and do things like that because of things that we've not controlled for ourselves in the laboratory. So we need to verify that what we are doing, handling of the specimens, is consistent. So finally, thanks again to Stago for inviting me to talk to you today about comparisons and ways to approach it. I've been Stephen Macdonald from Addenbrooke's Hospital in Cambridge. Thank you for watching.
Thank you for watching the Stago Educational Short. You can find other presentations by world-renowned experts on similar topics at www.stagowebinars.com. To learn more about the field of hemostasis and thrombosis, download iHemostasis from the App Store or Google Play Store onto your tablet. iHemostasis is a global education tool dedicated to the pathophysiology of blood coagulation, illustrated by clinical cases, designed for everyone from clinical professionals to students. Also sign up to our newsletter to keep up to date with the latest scientific topics, educational materials and giveaways at stago-uk.com. For answers to the most important coagulation questions, listen to our Ask Stago podcast, available on all popular streaming services. You can also submit your questions by email at ask@stago.com.